Urinary tract infection is the presence of microorganisms in the urine or tissues of the normally sterile genitourinary tract. Infections may be localized to the bladder alone or the kidneys, or in men, the prostate. Acute uncomplicated UTI occurs in women with a normal genitourinary tract and usually manifests as acute cystitis, as bladder infection or lower tract infection. Uncomplicated UTI occurs in individuals with structural or functional abnormalities of the genitourinary tract, including those with individual devices such as urethral catheters. Congenital abnormalities of the genitourinary tract predispose children to UTI. Proving UTI in a child or recurrent UTI requires further urogenital evaluation. Definitive treatment of UTI depends on the culture and sensitivity reports. Empirical treatment may be initiated while awaiting the reports. The main causes are bacteremia or septicemia, urinary tract obstruction, for example, enlarged prostate in adult males, and posterior urethral valves in infants or children. Symptoms are frequent painful urination, hematuria, cloudy foul-smelling urine, vomiting, suprapubic pain, and fever may be persistent and unexplained in children, and there may be feeding problems, diarrhea, and failure to thrive as well in children. UTI symptoms can be non-specific in young children. The signs that are usually elicited are fever, loin tenderness, suprapubic tenderness, and foul-smelling urine. Investigations: FBC, midstream specimen of urine for microscopy, culture and sensitivity, as culture urine after treatment, abdominal ultrasound scan in children if indicated. Main treatment objectives are to relieve symptoms such as fever and pain, to eradicate causative agent, to prevent complications, and to identify patients with abnormalities of the genitourinary tract. Non-pharmacological treatment: liberal oral fluids to encourage good urinary output, personal hygiene and proper cleaning after defecation. Pharmacological treatment: first-line treatment for uncomplicated UTI, give ciprofloxacin oral in adults 500 milligrams 12 hourly for 7 days, as in female 10 to 14 days. In children, 15 to 20 milligrams per kilogram 12 hourly, a maximum of 750 milligrams daily in 2 divided doses, or cefuroxime oral in adults 250 to 500 milligrams 12 hourly for 5 to 7 days, as in female, and 10 to 14 days in male. As the same for ciprofloxacin, 10 to 14 days in male. And cefuroxime in children, it gives 12 to 18 years, 250 milligrams 12 hourly for 5 to 7 days, and 2 to 12 years, 850 milligrams per kilogram 12 hourly, with a maximum of 250 milligrams for 5 to 7 days. 3 months to 2 years, and 10 milligrams per kilogram 12 hourly, with a maximum of 125 milligrams for 5 to 7 days. Treatment of uncomplicated urinary tract infections, including catheter-related stones, prostate enlargement, urologic abnormalities, and pregnancy. First-line treatment: to give ciprofloxacin IV in adults 400 milligrams 8 to 12 hourly for 7 days. Is to be administered over 60 minutes, or gentamicin IV if kidney function is normal. In adults, 40 to 80 milligrams 8 hourly for 7 days. In children 12 to 18 years, 2 milligrams per kilogram 8 hourly for 7 days. 1 month to 12 years, 2.5 milligrams per kilogram 8 hourly for 7 days. Or ceftriaxone IV in adults 1 to 2 grams daily for 7 days. children all ages, you give 25 milligrams per kilogram 12 hourly, with a maximum of 75 milligrams per kilogram daily. Amoxicillin clavulanic acid IV in children 1 month to 18 years, 20 to 30 milligrams per kilogram 8 hourly, with a maximum of 500 milligrams for 5 to 7 days. Neonates, those doubled in severe infection, so 7 to 28 days, give 30 milligrams per kilogram 8 hourly for 5 to 7 days. Less than 7 days, give 30 milligrams per kilogram 12 hourly for 5 to 7 days. Also, gentamicin IV, slow infusion injection over at least 3 minutes. In children 12 to 18 years, give 2 milligrams per kilogram 8 hourly. 1 month to 12 years, give 2.5 milligrams per kilogram 8 hourly. Or you can give sulfurosam IV in children 1 month to 18 years, 20 milligrams per kilogram 8 hourly, a maximum of 750 milligrams. Increase to 40 to 50 milligrams per kilogram, a maximum of 1.5 gram 6 to 8 hourly in severe infections. So neonates, double the dose in severe infections, IV routine only. With 21 to 28 days, give 25 milligrams per kilogram 6 hourly, and 7 to 12 days, give 25 milligrams per kilogram 8 hourly. Less than 7 days, give 25 milligrams per kilogram 12 hourly. So referral criteria: you refer patients who are very ill with recurrent UTI and persistent hematuria and congenital abnormalities to the appropriate specialist.